Abhishek, are you there? Uh, yeah, madam is there. Ma'am, can we start the program, ma'am? I'm Girida here.
I think Abhishek is having some technical problem. I'll just call him and check 1 second. Just hold on.
Yes, ma'am, please, please. I'll do that, ma'am. No problem. I'll do that, yeah. Ma'am, I think Abhishek is having some difficulty in logging on. I think there's some issues with connecting to the link we provided through using the Mac device.
Okay.
And start off you just give a brief introduction about and make the context, ma'am, for our fellows. I think once
Sure.
Abhishek comes along, we can start, ma'am. I already around 100 people are online now.
No, I know. I saw that. What about Bharati?
Bharati, are you there, Bharati?
Okay, fine.
Yes, ma'am. Thank you, ma'am.
If needed, I could start off if Abhishek is having a.
Yeah, I think Abhishek is having some concerns. Once he is online, you can start off, Bharati, if you want. Yeah.
Yeah, after ma'am gives the
Yeah,
introduction.
yeah.
Do
Over
you
to you,
want to
ma'am.
say something before I start off, Bharati? No.
No, ma'am, please
No.
you start, ma'am. Then
Okay.
after that, if Abhishek is not able to join, then I can pitch in, I meant. Yeah.
Yeah. Okay, fine. Good evening, everybody. We are very sorry for the delay. I think we almost delayed by 10 minutes. Our apologies for that. I think most of you know what is the topic we're having today. It may sound very boring for you, but please remember that it is extremely essential that we are all up to date with our infection control practices. Bharati, I'm just going to share the slides. 1 second. Sorry. Yeah. Can you see the slides? Bharati?
Ma'am,
Not
your
yet, ma'am.
screen,
Your
not.
desktop is seen, but your slide, I think PowerPoint you should maximize.
Is not seen?
No, only your desktop is seen, ma'am.
Okay.
Slides are not seen, ma'am.
Okay. Sorry. Now?
Yes, ma'am.
Okay, fine. All right. Sorry once again. Anyway, the whole session today is about infection control, and I'm just going to use a few slides to kind of wake everybody up and say why it's so important that we follow infection control practices. Bugs are everywhere, whether it's in the hospital, whether it's in the NICU, whether it is in the wards, and our hands definitely have bugs. I'm sure as neonatologists and budding neonatologists, all of us know this, but somehow in practice, we tend to ignore this fact. So please, I have always told my residents, when you walk into an NICU, just presume that you have an infrared glass and you can see all the bugs. And when you think like that, you will definitely make sure that you wash your hands and do all the necessary things that are required for infection control. This is a familiar scenario for all of us. 30-week, 1,000-gram neonate with no risk factors for early onset sepsis, other than prematurity, admitted in a level 3 NICU. And in this NICU, there was also an outborn late preterm with MDR Klebsiella, which has already there in the unit. So this 30-weeker developed RDS requiring CPAP, was on IV fluids, parenteral nutrition, started on enteral feeds within 24 hours, all going on very well, but suddenly deteriorates around 96 hours, requires invasive ventilation, septic screen positive, and the blood culture is positive for MDR Klebsiella.
Ma'am, sorry to interrupt you, ma'am. I
Yeah.
think your screen, it's in the presenter view. We are able to see the next slide also.
Okay. It doesn't matter. Just 3-4 slides, that's all.
Yes, ma'am. Fine, ma'am.
I don't know how to handle it, so we will just leave it like that.
That's fine, ma'am. Yeah, thank you.
Okay. So obviously all this is because of poor infection control practices through the IV fluids, through the ventilator, cross-infection, etc. And this is what we can certainly prevent. Now, just to give a kind of focus on, are we really having this problem? This is all data from India between 2018 and 2022. And you see that healthcare-associated infections range from 10% to 35% in various NICUs. These are all level 3 NICUs. But what is more scary is this data which came out recently from 5 district hospitals. The culture positivity is not very high, it's just 3.2%, but the case fatality rate is 36%. And what is more scary is the fact that MDR organisms, multi-drug resistant, are really this blue one, 80%, 75%. And therefore, I think we need to understand that multi-drug resistance has become a big problem in India, in our NICUs. Again, this information is basically to tell us that if we put in our effort and improve our infection control practices routinely or through a QI initiative, the CLABSI rates, the bloodstream infection rates can definitely come down. And this is again data from India. Mortality comes down, CLABSI and BSI have come down significantly. So my statement is very clear. Is it important to implement strict infection control measures in NICUs? The answer is yes, because is healthcare-associated infection a problem? Yes. Do we have multi-drug resistant organisms? Yes. Do interventions improve infection control practices? Do interventions to improve infection control practices, does it help in reducing HAIs? Yes. So therefore, this is just to tell all of us sitting over here, and particularly the fellows, that please remember this is all our responsibility. There's a general tendency for residents and doctors to believe that this is a nurse's problem, or the infection control nurse will handle it. No. We as doctors, we as residents, we as fellows are equally responsible to ensure that all our babies are safe in the NICU and they don't get into problems, because they're very susceptible. They have to have intervention. And if we don't take precautions, they're going to land up with being septic. So the message is very clear. Before Bharati and Abhishek go on to tell more details, zero infection may be difficult. According to me, not impossible, but zero tolerance to infection is the first step. And that is what we need to start off doing. So my sincere request to all the fellows and faculty listening, let's really make sure that we are very serious about this problem. So I just wanted to share these few slides. I think, Dr. Bharati, you can take over now. Bharati is currently faculty at St. John's Medical College, a DM neonatologist, and like Abhishek, very, 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 very passionate about neonates, their problems, and infection control. Bharati, over to you.
Thank you so much, ma'am, for this introduction. Can I just ask if Abhishek is online? I'm not sure. He was there. If he's not responding, I'll just take over.
Bharti, can I share the screen?
I have not got your PPT. Can you send it across?
I have emailed you.
I stopped sharing the screen.
Ma'am, can you give me just 1 minute? Yeah, I got his PPT. I'm just downloading it. Abhishek, you can just start talking. Meanwhile, I'll try to load the slides.
So, good evening, everybody. So, sorry for that interruption. There was some technical glitch to share Zoom. So, today we will discuss about infection control. I think a couple of weeks back, we had the IAP fellowship exam. We realized that most of the participants had difficulty just to do proper hand hygiene. So it felt really bad that after 1 year of neonatology practice, people were struggling to do hand hygiene before handling a newborn. And NICU has a lot of procedures, especially a lot of invasive procedures from central line, intubation, suction, a lot of asepsis. Tomorrow, you're going to be leaders in neonatology. And I hope we should have enough confidence to handle newborns with zero infection so that we optimize outcomes across the country. So with that, today we thought with Girdhar sir's guidance, we were able to discuss infection control, basics and beyond. So in the next couple of minutes, I will be discussing hand hygiene, ANTT, CLAPSy. Next slide, Bharti.
Yeah.
Next slide. So in next couple of minutes, first I will discuss with hand hygiene. Why hand hygiene? I think Swarnarika ma'am actually has already discussed the importance, because healthcare associated infections is the one which is going us to make a difference in the babies what we manage. And we'll discuss subsequent steps. Next slide. So our unwashed hand, if you're going to plate it on a culture plate, is going to have full of bugs. Our hands can be visibly dirty, can have transient flora. These are the bugs which are going to be present in our superficial layers. They can range from our common organisms like Staphylococcus aureus, gram-negative organisms, which typically cause healthcare-associated infections like Klebsiella, Acinetobacter, to various gram-negative bugs which causes healthcare-associated infections. We also have resident flora, which are present in deeper layers of our skin, which can range from typically our commensals, that is our corns, diphtheroids. When we do routine hand hygiene, that is hand wash or hand rub, we typically take care of our transient flora. When we do a deep surgical hand hygiene, we even get rid of resident flora, because in surgeries or in the sensitive babies, especially our extremely low birth weight babies, these resident flora can infect them. Next slide. So as I said, there are 3 types of hand hygiene: hand wash with soap and water, hand rub, surgical antisepsis. So I know we have a chat function. Can you type in the chat box, what is the duration of hand wash? In your chat, in the chat box, what is the duration of hand wash? I can see some answers. They say 40 to 60 seconds. Somebody has said 30 seconds.
2 minutes, 3 minutes.
Somebody says 2 minutes. Somebody says 2 to 3 minutes. Somebody has written 3 minutes. 2 minutes. I know we are a democratic country. We have different answers ranging from 30 seconds to 3 minutes. So the right answer actually is 40 to 60 seconds, right? So what's the duration of hand rub?
Answer is already there, Abhishek, in your slide.
I know, madam, I know. I'm just seeing if they can look at it and write the correct answer. Because I'm getting even wrong answers despite that. I hope the wrong answers are by the new fellows who have just joined. So hope the exam going fellows must be answering rightly. The answer is 20 to 30 seconds. I hope all of you are aware about the steps of hand wash. Unfortunately, I cannot play the video at the moment. I think hand wash actually, all of you are aware about the WHO steps, especially hand rub as well. Remember, it's very important to do these steps because we protect the newborn from any infection. Can we move to the next slide, Bharti? So can you type in the chat box, when do you do routine hand wash? When do you do hand wash? Yeah, I'm glad most of you are answering. Some say 5 moments, some say hands are visibly soiled. And the right answer is 5 moments, of course. We'll get back to the 5 moments. So when is hand wash superior over hand rub? When is hand wash superior over hand rub? I think most of you are answering this. Hand wash is superior over hand rub before invasive procedure or after contact with body fluids, right? So we'll come back to the 5 moments of hand hygiene. We know when is hand wash superior. What are the contents of a hand rub? What are the contents of the WHO recommended hand rub? Somebody says 2% chlorhexidine. Somebody says only alcohol. Somebody says ethyl alcohol. I think it's a good time for all of us to go back and check our hand rubs. What do they really contain, right? What type of alcohol, how much percentage of chlorhexidine as well. So it normally contains 70% of isopropyl alcohol or different types of alcohol, typically 70% and 0.5% of chlorhexidine, right? So why is there chlorhexidine apart from alcohol in the hand rub? What's the use of chlorhexidine in your hand rub? Somebody has written hydrogen peroxide, H2O may not be good for your hands. Chlorhexidine may not help you with spores. Mridula, it may not help you with spores. I'm not sure what it is, HLD. See, the chlorhexidine will give you residual effect. It will also act as an emollient for your alcohol. Probably it will reduce your dermatitis. So the two main purposes, it has a residual effect as well as it acts partly as an emollient, reduces dermatitis if you use pure alcohol. Bharti, next slide. You must have the answers. Next slide. So I think you answered 5 moments of hand hygiene, that is before touching a patient. Next slide. Basically, there are 2 befores. Previous slide. 2 befores, 3 afters. Before touching a patient, before clean aseptic procedure, after touching a patient, after touching patient surroundings, after body fluid. Remember, all of us are good before touching a patient or before a procedure. What we forget is after touching a patient and after touching patient surroundings, especially the patient file, the monitoring sheet, the monitors, when we silence them, or the ventilators. So after touching a patient, after touching patient surroundings are the ones which we commonly forget. We need to remember them. Of course, most of us would do after body fluid exposure. Next. So you have an interesting question here again. This is a common hand wash. You can see a tap, you can see somebody washing hands, you have a soap present there, you have a towel to dry. Can you list out the common mistakes in this particular picture in the chat box? In today's session, we didn't want to give you the answers. We wanted you to think and compare what you have in your unit, what changes you can bring. Yeah, I can see great answers. Yeah, most of you have answered. Remember, it's always good to use a liquid soap. It's good to use a elbow operated tap. I know the sleeves are not folded. Probably sink is too shallow here. The water spillage can happen. And no towel, probably you can use autoclaved or a single use cloth or a tissue paper, which is autoclaved. Air dryers, I'm really not sure how safe they are as per the WHO because it can blow bacteria if the filters are contaminated. So dryers may not be a good option. You can use a single use napkins or a single use tissue papers. So thank you for that answer. Okay, next slide. Next, remember why we don't wash our hands. Either we are too busy or insufficient time. Sometimes patient needs take priority, especially when a child is throwing a seizure, child is an apnea. Sometimes it is understaffing or overcrowding. So remember, we are not bad. We may be just busy. Sometimes sinks are inconveniently located. That is, you enter the NICU, sink is present at the end of it, or sink is not present after every 10 patients. So, or sometimes even we may have sink, there is water inadequacy, or the soaps are not inappropriate. Soaps are deficient. It's because of poor design. Lack of soap and paper towels again says poor design. Sometimes our hand washing agents can cause irritation and dryness because of poor product. Sometimes we feel there is low risk of acquiring infection from patients. That is, we enter from our counseling room to the NICU. We say that we have not handled anything. We need more education. This is quite common, especially when we handle patient surroundings, again, which needs more education. Next slide. So if somebody wants to improve the hand hygiene in their unit, you can go through freely accessible open access WHO multimodal tool, which says you need to improve your system with a multimodal strategy. One, system change. That is, you need to have access to safe, continuous water supply and towels. We should have alcohol-based hand rub at every bed. We need to have regular training and education. Third, we need to have regular audits and on-time feedback. Fourth, reminders in the workplace, that is at your hand hygiene place, have a WHO steps of hand hygiene. So you can just have protect the babies from protect yourself as well, to remind the people for doing hand hygiene. And again, we need to have institutional safety climate. That is, every month we need to say, we need to present our hand hygiene data. We need to celebrate hand hygiene days, and we need to have regular training as part of organization safety culture. So with that, I'll come to the end of hand hygiene. So let's move to the next slide. So let's move to the second aspect, that is aseptic non-touch technique. I think it's not uncommon to see syringes lying on the bedside, the canalization site with a non-transparent dressing which is soiled. We forget to clean the hands before a procedure, and we can see all the vials lying around the bedside, or the key parts are not cleaned adequately. Remember, these are not uncommon in a busy unit. So you can think yourself which you can get it right. Next slide. See, the problems with aseptic technique, what we do, ranging from IV cannula insertion to fluid administration to blood culture collection, there is no standard. We have different people do it differently. We have poor equipment choices. Many of us may not understand asepsis. Hand cleaning may not be consistent. These challenges and variability in clinical practices place patients at risk of healthcare associated infection. Remember, apart from a poor hand hygiene, poor asepsis during procedures places babies at risk of healthcare associated infection. Next slide. So in the next couple of minutes, let us discuss aseptic non-touch technique. Next slide. What is this aseptic non-touch technique? Aseptic means we prevent pathogenic microbes from being introduced to susceptible sites by hands, surfaces, or equipment. Non-touch, preventing contamination of susceptible sites by hands, surfaces, or equipment. Technique, basically we identify the risk of contamination and choose the right field. Basically here we ensure asepsis and we do not touch critical parts. Next slide. The ANTT framework has 10 principles. In simpler terms, we standardize all the invasive procedures, we keep a aseptic field, and we protect key parts and key sites. I'll come to these individual parts. Next step, next slide. Aseptic field management. I think we have 3 different types of aseptic field. General aseptic field. You can use a clean steel or a plastic tray for assembling your items. Critical aseptic field, we are all aware, we do in operation theaters. Microcritical aseptic field. If you remember the first slide of ANTT, which I showed, you can actually protect your syringe tips with the knobs, or you can keep it in the sterile covers so that you protect the tip of your syringes from getting contaminated in a microcritical aseptic field. You can also use your glove paper, which is sterile, or the knobs. This is your aseptic field. Next slide. Key parts are the most critical parts of the procedural equipment, which if contaminated are likely to cause infection. Your cannula sheath, your syringe knob, your tip of your IV line hub. If you do not touch them, you cannot introduce infection. So you need to protect your key parts. Next slide. Key sites are medical device access sites or your open wounds. Like if you're placing a cannula, your cannula sheath is a key part, while the skin becomes a key site. If you're administering a fluid, your extension tubing becomes a key site, your syringe hub becomes a key part. If you do not touch them, you cannot introduce an infection. Next slide. Hope it's clear. We need to protect our key parts and key sites from contamination. This picture is self-explanatory. Next slide. One of the important steps is scrub the hub. We use alcohol or chlorhexidine gauze and protect our key sites. We scrub it for 15 seconds. Allow it to dry for 30 seconds. This is a schematic picture which shows when we have placed a fluorescent dye and when we scrub it for 15 seconds, you can see the three-way extension is completely decontaminated. When you do it only for 5 or 10 seconds, it's not completely decontaminated. So scrub the hub needs to be done for 15 seconds and we need to allow it to dry for 30 seconds. Next slide. This is a picture of standard IV line maintenance from the ANTT.org. The steps are very simple. Hand hygiene. You prepare your aseptic field, that is clean the tray with spirit or Bacillol spray. Arrange the necessary items. Hand hygiene. Wear appropriate gloves. Draw the fluid. Then before administering, we use SAS technique, that is, first we do scrub the hub for 15 seconds, allow it to dry for 30 seconds. First we administer saline, ensure cannula patency, administer the fluid or the antibiotic. Finally, we administer saline so that it doesn't remain in your cannula. So your cannula duration is thereby increased or there is no backflow with blood so that there is no thrombophlebitis. It's called SAS technique followed by appropriate decontamination. Next slide. This is one of the quality improvement approach which we did in our unit. By following aseptic non-touch technique for administration of fluids, we could actually reduce healthcare associated infection. This is a run chart. The picture, x-axis says the months, y-axis the healthcare associated infection per 1,000 patient days. You can see in the month of Feb, from about 25 per 1,000 patient days, we could actually reduce it to single digit per 1,000 patient days by using quality improvement approach. Next slide. This is a similar SOP which you can make for your unit for a blood culture collection. Your key part will be your syringe hub or the needle. Your key site will be your bactec bottle hub. So you need to be cautious while transferring and collecting blood. Next slide. This is the evidence table from NNF clinical practice guidelines. If we use aseptic non-touch technique, we can reduce healthcare associated infection from 19 per 1,000 patient days to 15 per 1,000 patient days. Remember, it is not percentage. Per 1,000 patient days, there's a great reduction. And more importantly, in CLABSI, it's almost 80% reduction in CLABSI when you follow ANTT. Next slide. So in summary, standardized common invasive procedure with ANTT principles. It involves aseptic field management and protection of key parts and key sites. Next slide. Last, we'll move to CLABSI. Everybody here will agree with me. Central line placement is an essential intervention to deliver TPN. In India, central line placement in VLBWs, 22% of them will require central lines, and majority of VLBWs will require central line placement. So it's important for us to follow CLAPSI bundle because CLAPSI rate is nearly 20 per 1,000 patient days. Some people may think gram negative may not cause CLAPSI. What if cons will cause CLAPSI? The recent evidence says even cons infection, although it may not cause meningitis commonly, it may cause cognitive disability in preterms. Next slide. Hope everybody is aware of CDC LCBI 3 definition of CLAPSI. A line confirmed bacterial infection where central line was in place for more than 2 calendar days on the date of the event, with the day of device placement being day 1, and the line was also in place on the date of event or the day before. Meaning, let us say you place a central line on Monday. From Wednesday, the baby comes under surveillance for CLAPSI, and the surveillance continues 2 days even after you remove the central line. The definition for less than 1 year, there's no newborn specific definition by CDC. They should have at least one clinical sign, fever or hypothermia or apnea or bradycardia, and organism identified from blood is not related to an infection at another site, and the same common commensal is identified from more than 2 specimens 2 days apart. Right? If it's a commensal, we need from 2 specimens. So the challenge here, it's very evident. Fever is rare in a preterm. Hypothermia may not see if the baby is in incubator. Only apnea or bradycardia may not suffice because apnea can be seen because of other reasons. And blood related to another site is okay, but most of us may not send 2 cultures when we have a cons in the question. Next slide. Remember, CLAPSI will happen typically with the pathogen migrating along the external surface, which can typically occur within the first 7 days. That is, CLAPSI can happen from skin organisms, contamination from hub or needleless connector if you do not follow scrub the hub, or contaminated infusions. Rarely, it can also happen from hematogenous route. Next slide. So CLAPSI can happen not just because of insertion, mainly because of poor maintenance and excessive or unnecessary use of central line. You have a moderate preterm, just because the unit or the nurses are not aware of cannula, we place a central line. That's a wrong practice. Or just for antibiotic completion, we place a central line. Again, it's an excessive use of central line. We are placing the newborn at risk of CLAPSI. Next slide. So we've already discussed the importance of hand hygiene. Hand hygiene is essential before placing the line, accessing the line. It's very important to give a in-time feedback. Next slide. For insertion of central line, we need to use maximal barrier precaution, cap, mask, gown, gloves, drape. I'll come to skin antisepsis. There is no role of routine fixation with silver alginate dressing or antimicrobial impregnated lines in NICU. A good dedicated team will have less break-in asepsis or less problems with line migration or line malpositions. So let's get back to the chat box. What should we use for skin preparation of central lines? Should we use alcohol alone, alcohol with betadine, or chlorhexidine alone? You can answer in the chat box. Bharti, next, probably the question will come in. Should we use alcohol alone? Previous. Alcohol alone, alcohol with betadine or chlorhexidine? I can see alcohol with chlorhexidine, both SBS, I hope it is alcohol, betadine, alcohol. Chlorhexidine will be alcohol. Okay, next slide. I think all of you have answered, not just alcohol alone. Next. Let us look at the comparison of alcohol with povidone iodine with chlorhexidine. So this study by Kiran et al. Looked at chlorhexidine alcohol versus povidone iodine for insertion cleaning site. They saw CLABSI rate was not different. 5% in the povidone iodine group required thyroxine, meaning the iodine suppressed the routine thyroid production, probably by Wolff-Chekhov effect, which we have studied in our physiology books. So 5% babies had hypothyroidism when they used povidone iodine. Skin damage, there was no difference. So, but CLABSI rate was not different when we used both of them. Next. So this was a past paper presented by one of our colleagues. So where they compared chlorhexidine versus chlorhexidine in alcohol versus alcohol, iodine, alcohol. They have not used it for central line, but they have compared this RCT for peripheral line. So I've taken this because it is a similar thing for us. There was no difference in infection rate or dermatitis or thyroid dysfunction, but 85% of newborns had detectable levels of chlorhexidine in serum. I'll come to this. Next slide. So whatever we have learned is the difference in CLABSI rate is not different when you use alcohol with chlorhexidine versus betadine. With one study says when you use betadine, be prepared for 5% babies having hypothyroidism. What about chlorhexidine? The concerns with chlorhexidine is the in vitro studies have demonstrated damaging effects on odontoblast, fibroblast, human epithelial cells, and neuronal cells. We are not sure about neurotoxicity or there is lack of long-term data with these studies. What I would suggest is with available data in extreme preterms, probably alcohol or alcohol betadine may be better over chlorhexidine. Probably above 35 weeks, you can comfortably use chlorhexidine 2%, but below 35 weeks, in the lack of data, I would say exercise caution. Next. Next. So I've told with the dedicated team, your malpositions will be less, fixation will be better. Next. Let's come to the important aspect, maintenance of lines. Remember, as you do for insertion, even for maintenance, we need to have 2%. We need to use gowns, complete barrier as though what you did for your insertion. The concerns will be port access. Should we use antibiotic locks? I think administration of medicine, I've already told, we need to use scrub the hub. We need to review dressing integrity and site cleanliness daily. Next. Again, there is an interesting question for all of you. How many ports can we connect to a central line? 1, 2, 4, or 6? Because sometimes we have 3 or 4 inotropes, 3 TPN lines going on. How many ports can we connect to a central line? Or how much is permissible to prevent CLABSI? Somebody says 3, somebody says 2. What if babies on dopamine, dobutamine, adrenaline? Will be challenged to say just 2, 3, 4. So remember, ideal is just 4 is the ideal is just 4 port we can connect to a central line. How many port access per day we can do? Meaning, you have a line, how many times you can break that line for sampling or connecting IV fluids. How many times you want to break the line? Is port access. Yeah, it's minimum as possible. How much it should be, Ruby? Okay, next slide, Bharti. See, it's good to use needleless closed connectors. Port connections should be less than equal to 4. Port access per day should be not more than 2 per day. Never keep your UVCs for sampling as much as possible. Next. We already discussed scrub the hub. Next. So prophylactic antibiotics. So some of the units use routine antibiotics or they hesitate to stop antibiotics when they have central line. Some of them give routine fluconazole or amikacin, but they're not evidence-based. Remember, some people, as per evidence, some people use vancomycin lock 20 to 60 minutes. Some studies have used fusidic acid or amikacin. What the studies have shown is there's definite reduction in CLABSI, but remember, it's a limited evidence. We do not have safety data on resistance pattern. It's a low quality evidence. And some people also administer antibiotics at the time of removal of central venous catheter. There's a single RCT with cefazolin. Next. So despite Cochrane evidence, so far we were not using antibiotic locks, but the recent CDC 2022 for newborns recommends if you have CLABSI, despite very good insertion maintenance bundle, you can consider prophylactic antibiotic locks as a last resort. Next slide. Remember to empower your nurses to remove the line, have a unit policy to remove the lines, never let for the consultant to decide when to remove lines. Typically, you can remove once you're out of vasoactive support or TPN. Don't use it for the completion of antibiotics. Next slide. So with the CLABSI bundle approach, the clinical practice guidelines from NNF says you can 60% reduce CLABSI in your unit. It's good to have CLABSI bundle. Next slide. Probably you can use it as a bundle approach in your unit for insertion, hand hygiene, standard barrier precaution, have a dedicated team. Probably alcohol is better than chlorhexidine for preterms. No role of antimicrobial dressing or antimicrobial impregnated catheters. For maintenance, let us use less than 4 ports, less than 2 port access per day. Scrub the hub is important. 2% job. Limited evidence, I would say, for prophylactic antibiotics. Change tubings every 48 hours, unless for lipids. Have a unit-specific removal policy. For UAC, probably 7 days. UVC 7 to 14 days, as per the latest CDC 2022. Pick line as long as possible. No prophylactic line change. With that, I would like to finish my session. Thank you, Bharti, for helping me out with the slides. Over to you, Bharti.
Yeah, thank you, Abhishek, and thank you, Swarnarekha ma'am and Dr. Giridhar for this opportunity. So I think Abhishek has actually, and Swarnarekha ma'am has made my life pretty simple. So the most important focus has been actually hand hygiene, ANTT. But what I'm going to share with you is that it almost takes a village, right, to raise a child. You cannot raise a child independently. So everybody around you actually makes a difference. So I am going to touch upon the little not so well-known things, that is standard precautions, WAP bundle, and housekeeping procedures. So just give me a minute before my slides load. Yeah, I think my screen is visible. So of course, I think ma'am started with this, that I think the next antibiotic discovery has been almost 15 to 20 years ago, and bugs are thriving. So the only way we can overcome them is prevention. And the overview of infection prevention encompasses all these categories. It starts with hand hygiene. You cannot get away with hand hygiene even if you do everything right and do not get hand hygiene right, then everything is going to go wrong. Bundle care, standard precautions, housekeeping, and auditing. So here what I'm trying to do is, of course, there is a gap between what we know and what we do. But first, I'm going to fill the knowledge gap. And then after that, we have to see how we can prioritize the implementation gap. So healthcare associated infections, we do not call them hospital acquired infections anymore. It is called healthcare associated infections. The overall prevalence is almost 9%, and the incidence is around 20 per 1,000 ICU days. And one of the most common infections, if you can see, is usually line associated, that is CLABSI, but also ventilator-associated pneumonia, CORTI, and surgical site infections all encompass the burden of healthcare-associated infections. So how does infection spread? Okay, so let me ask you one question. You can answer yes or no in the chat box. Early onset sepsis is acquired from the mother. Say yes or no. Only from the mother. So because I'm asking this question, some people have answered no. Many people have answered no. That's great to know. Yes, a portion of early onset sepsis, as we know, is from the mother, but then the majority of them are actually preventable. They actually come to the baby during the resuscitation. So there are three modes of which infection spreads. One, it could be across the placenta, across the maternal birth canal, and across the environment. And amongst everything, what we can do to prevent is to take care of us and the environment. So these are some of the neonatal interventions. So for the well baby, even the well baby in the ward should not get an infection. For them, hand hygiene, cord care, skin care, breastfeeding, KMC for the small baby, avoidance of native medicines and harmful practices, unnecessary IV fluid should not be given to them. And for the baby in the NICU, I think Dr. Abhishek has already started with hand hygiene and with a part of bundle care. I would be harping on the rest of them, that is standard precautions, breast milk, kangaroo care, antibiotic stewardship, and housekeeping practices. Even though Abhishek has covered extensively about hand hygiene, I think no infection control class is complete without hand hygiene. So this is again, what is this picture? This is the unwashed hand. You can see how much bugs are on them. And these are the steps of hand hygiene. And I request all the participants present here to practice the steps of hand hygiene every single day so that it comes to you like subconsciously. Okay, so the hand rub is practiced for 20 to 30 seconds and hand wash for 40 to 60 seconds. And these are the 5 moments of hand hygiene. So one fact is that it's not just hand washing, but also drying of the hands is a key factor in reducing the risk. All of us know the steps of hand washing, but then drying should also be done in a gentle and a patting manner so that you do not cause more dermatitis, and that prevents you from doing hand wash or hand sanitizing or hand rub, and as a result there would be spread of infection. The other things in infection prevention: do not wear watches, do not wear links, keep your sleeves above the elbow. It's called NBE, nothing above the elbow. No nail polish, keep your nails short. And these are equally important to practice yourself and also to all the people around you. So that is about hand hygiene. And coming to standard precautions. So standard precautions are something which we use in day-to-day life to prevent transmission of diseases which are acquired by blood, body fluids, non-intact skin, mucous membranes. And these have to be done across the groups, whether the baby is symptomatic or asymptomatic. So what are all the components? One is hand hygiene. Use of personal protective equipment. I cannot but emphasize, after our COVID, we all know that respiratory hygiene is as important as any other hygiene. How to use cough etiquette, patient placement, cleaning and disinfection, needle stick injury, safe injection practices, and waste disposal. Now, it is impossible to cover all components of standard precaution in a half an hour lecture alone. So I would be just giving you the headings, but then I would cover some important parts of them. One is personal protective equipment. The personal protective equipment which we use are gloves, mask, gown, and goggles. And all these personal protective equipment, we should know how to use them in day-to-day procedures. So this is a video of glove use. So all of us wear glove for so many procedures. One thing which we need to know is, before wearing a glove, it is extremely important to dry your hands. Keep the glove on a aseptic surface, like an aseptic field. Then handle the glove by touching the sterile part of the glove. While wearing the first glove, this is how you wear the first glove, and this is how the second glove should be worn. And believe me, this is not easy, and it comes only with practice. Okay. The second thing I also want to emphasize in standard precaution is how to place your patients. Every time you are admitting a patient, think of what this patient has, what infection this patient has, and how it can transmit to other patients. There are 3 transmission-based precautions. One is airborne precaution, droplet precaution, and contact precautions. Airborne precautions are those with varicella, measles, or untreated tuberculosis, that is not diagnosed and not treated. These babies should not come into the NICU at all, because by just breathing the air, another baby can get infected. The second is droplet precautions. Droplet precautions can be when the baby is coughing, such as mumps or meningitis. And the last is contact precautions. The contact precautions are something which we do in day-to-day life, that is a baby with MRSA, MDR. So all these babies, for contact precaution, should be actually isolated in a separate room with 1:1 or 1:2 nursing. Ideally should have a negative pressure room. A separate cap, gown, and mask should be worn for this. Or if you do not have a separate isolation, these babies, we should know that we should have a cohort for them. So I have an MCQ here. Which of these following is not a transmission-based precautions? So contact precaution, droplet precaution, airborne precaution, and standard precaution. So answers. I think this question is pretty simple. Okay. Some people are awake. Thank you. So, of course, standard precautions should be applied to everybody. Transmission-based precautions are for infants with specific type of diseases. So this is just to sensitize you. When you are actually having an admission into the NICU, think about transmission-based precautions and think about patient placement. So which piece of personal protective equipment is essential for droplet precaution? So droplet spreads by usually the coughing or droplets which are across. A surgical mask is necessary. So I think Dr. Abhishek has already handled about bundle care. What I'm going to handle about is the VAP bundle, that is ventilator associated pneumonia. Any bundle has 3 components: insertion, maintenance, and removal. So does the VAP bundle. So for the VAP bundle, the most important part is the endotracheal tube and circuits. So the insertion bundle will look after the endotracheal tube insertion. The maintenance bundle would be about care of these endotracheal tubes, heating, humidification, suction, colostrum, oral care. And of course, removal bundle is about as soon as possible, we have to get this baby out of the ventilator. So during a intubation, what and all personal protective equipment would you use? Please answer in the chat box. How many of you would wear cap, mask, wash your hands, gown and glove, only gloves, gown and gloves, only cap, mask, glove? Okay, so there are varied answers. So for an older child or a pediatric intubation, maybe the standard way is to use sterile gloves. But for a neonate, even this small tube insertion can be a foreign body, which can cause intense inflammation in the lungs, which if it is not handled properly. So endotracheal intubation, just like any other procedure, should be handled with all care. Cap, mask, hand wash, wear a sterile gown, and then gloves. Okay. Oral intubation is preferred over nasal intubation. And can any of you tell me what is wrong with this picture? Let us see how many of you are awake at 9:40. So look closely at the ET plaster. So if you're on duty and see an ET plaster like this, would you walk away? Would you do something? I'm not sure about tube position, but then you can see that this ET plaster is almost getting displaced. If this baby were very active, there would be tube displacement. So ET security has to be inspected every 4th hourly, and we need to avoid unplanned extubations. That is one of the major risk factors for ventilator-associated pneumonia. Taking care of this equipment, that is heating and humidifying gases, inspired gases at 37 degrees and 100% relative humidity is a must. The water should be filled by an autofill technique. And we should use distilled water and no other water. Unnecessarily, we should not open and handle this humidifier water. Once this is contaminated, all this is going to go into the baby's lungs. There should be no condensation. If there is a reusable humidifier, which is not actually acceptable, we need to change the humidifier. But if there is a closed circuit, we do not change the humidifier. And all condensates, you do not remove the ventilator tube, do this on and spread all the infection all over the floor. We should change circuits only when it is visibly soiled or malfunctioning. Okay. And all ventilatory circuits, oxygen therapy, everything should be handled like sterile equipment. All systems should not be in standby more than 12 hours. So we all have resuscitation bags and things like that. They should not be on the patient's bed. They also should be treated as very sterile equipment. What should be the position of the baby on ventilator and what should be the position of circuit? It should be up or it should be down. Can you please answer in the chat box? Position of the baby. Okay, so the ventilator tubings, it's very important that the ventilator tubings are on the side like as shown in this picture and not standing up. Otherwise, all the condensates will go into the baby's lung. It should be parallel to the baby. Similarly, the head end of the baby should be elevated to at least 30 degrees. One of the most important things in VAP prevention is using of this closed suction. This is supposed to be used if the baby is on ventilator for at least more than 3 days. And another thing that we have to do is no routine use of normal saline during suction. And every suction should be protected, which means we have to measure the suction length and then insert as much as it is measured. It should not, the suction catheter should not touch the carina. And all the suction procedures should be completely sterile. So what is this? In older children, of course, there are many types of oral care, but in newborns, we are blessed that we have mother's milk or colostrum, which can be applied as oral care. And this is rich in immunoglobulins, and this is known to prevent VAP. So the other components are, we should prevent gastric distension, that is keep the feeding tube open. So how many of you will feed a baby on a ventilator? Yes or no? Okay, so everybody agrees on feeding, and that is quite reassuring. So one thing is, feeding helps these babies actually come out much faster than giving IV fluids. It helps in nutrition. Every day we need to assess extubation readiness. So this is one of the videos on endotracheal suction. This was a video which was shot in real time, and this was for the purpose of audit only. So you could say what are all the positive points in this endotracheal suction video and the negative points. Okay, any answers? Do you want me to play the video again? Okay, good. Gloves, somebody said. No gloves worn by the second person, not measured. 2 personal handling, second. So that is very right. Yes, so everybody should wear at least clean gloves, especially the first person should wear a sterile glove. So you can see that the first person is wearing a sterile gloves, is using the paper to handle this. And the second person, of course, is not wearing the glove. That was the minus point. So this is a VAP audit tool, which looks at endotracheal tube security every 4th hourly, whether the condensation is present or not, whether it was a sterile procedure, gloves are used, 2 healthcare personnel are present, no normal saline use, and protected suction. In addition, every baby should have a head end elevation and ET tube should be slant. So, which strategy is not a typical of a VAP prevention bundle? Okay, so the answer is C. Somebody answered pre-oxygenation 100%. In neonates, we do not pre-oxygenate to 100%. 100% oxygen is always harmful. Okay. So you can raise the oxygen by 10 to 20%, but definitely not to 100%. So yes, the answer is C. And which of the following practice should be emphasized for preventing VAP according to the bundle guidelines? Yes, so again, the answer is C, that you should not use routine prophylactic antibiotic just because the baby is on ventilator. There should not be frequent change of endotracheal tubes. There should be a weaning protocol which is implemented. So the last part, that is housekeeping in the NICU. Yes, all of us look at hand hygiene, all of us look at bundle care, but housekeeping is one of the toughest parts in infection prevention, at least according to me. So in housekeeping, I will run through. The first part is environmental cleaning. So there are 2 parts in the NICU, that is a patient care area and the non-patient care area. So the housekeeping should go from the patient care area to the non-patient care area. And then it has to, that is floor mopping should go from this patient care area to the nursing station and outside to the entrance area. And these are the solutions which are commonly used in the NICU. They are, one is phenol solution. Phenol solution is 5% and that is commonly used for floor mopping. Yes, different NICUs would have different protocols. you should know what is there in your NICU, and you should know whether the dilution is being done appropriately. Benzalkonium chloride is Ashakart, which was used in the suction equipment. Bacillocid is one of the glutaraldehyde compound, a quaternary ammonium compound, which is used for daily cleaning, and 1% hypochlorite is also used for daily cleaning and terminal cleaning. Now, I will tell you some common equipment in the NICU. So you will have to tell me what is the modality of sterilization or disinfection. So baby linen, blanket and cover, what would you do? You would send for ethylene oxide, you would send for autoclaving. Yes, so answer is autoclaving. The cotton and gauze, we send for ethylene oxide. Feeding utensils are autoclaved, and swab and container medicines, if they are after washing, they would be autoclaved. So this is the frequency, and this is a protocol of who would be doing this. Procedure sets, anything with metal, we usually autoclave. So can anyone tell me how will you clean a tape or a pulse oximeter probe in the bedside? What method would you use? Or a thermometer? Yes, so spirit or alcohol is the way to clean this. And laryngoscope, in laryngoscope, we have to dismantle the batteries, the bulb, clean it well, and send it for autoclaving or after every use. Or there is also 2% glutaraldehyde, which for sterilization, it has to be 10 to 24 hours, for disinfection, 15 to 20 minutes. Next, face mask, what would you do? Resuscitation bags, any answers? So these are all plastics. So plastics generally cannot be autoclaved. So they will have to undergo ethylene oxide. So usually they are cleaned, they are dismantled, clean and sent for ethylene oxide with date written. Weighing machine is one surface where everybody is, every baby goes, it is shared. So it has to be cleaned before and after use. Similarly, infusion pumps. Now, oxygen hood. So what you should not use on an oxygen hood? Can anyone tell me? Yes, so you should not use ethyl alcohol, otherwise your hood will be discolored after some time. Radiant warmer and incubator, daily it should be cleaned. If the baby has culture positive sepsis, then it has to go for something called as a deep cleaning with a higher percentage of solution. So ROP, I know all of us do ROP in the NICU. The speculums should be washed, clean and sent for either ethylene oxide or for autoclaving. Ventilator and reusable tubings, you should do ethylene oxide. If they are not reusable, it has to be discarded after single use. So remember, every area in your NICU can be colonized with germs, so especially surface, shelves, walls, nursing stations, door handle, phone. These are all what are called as, especially door handles and phone are the high touch areas, and these have to be cleaned at every shift. Similar to all these equipment, these are also the equipment we have to look after. They may seem very small to you, but then of course they also can be cause of infection. So AC, duct cleaning has to be practiced. Air handling is equally important. Refrigerator, bucket and sink. So like this, every equipment in the NICU should have a cleaning protocol and it should be periodically audited. More than so that comes to the end of the housekeeping practices. The other things which directly or indirectly contribute to reduce infection, probably directly, is breast milk and KMC. So early use of colostrum, lactation promotion, trophic feeding or protocolized feeding, probiotics, ANTT for even milk preparation, that is for mixing HMF into breast milk, use of donor milk, all these also help prevent infection. And antibiotic stewardship is again a separate topic itself. If we have to summarize antibiotic stewardship in one line, I would say 4 Ds: right drug, right dose, right duration, and appropriate de-escalation. So ensure that we have periodic checks for housekeeping, a policy for every item in the NICU, and ensure that the concentration is being maintained. I think all of us spoke about so many things. But how can we integrate everything into our day-to-day life? We cannot do everything or change everything in one day. You have to take one problem, use the principles of continuous quality improvement, and slowly see the change in your own NICU. So to summarize, we have to be strict about hand hygiene, not only to yourself, but also to others. Central line needs all the care in the world. We need to handle it very well, respect it. Peripheral line requires a similar care. Handle ventilator and ET tubings with the same respect. Keep the NICU clean. Have a protocol for every item in the NICU. And remember, whenever you have an opportunity, ensure that baby gets mother's own milk and KMC. Thank you. Over to you, Giridhar sir and Swarnarekha ma'am.
Giridhar, you want to make some comments? Giridhar? Okay. I don't know if there is time for questions. We're already at 10, almost 10 o'clock.
Yes, ma'am. Can you have a final comments from you, ma'am?
No, but any time for questions, Giridhar?
Ma'am, you are muted, ma'am.
Oh, I'm so sorry. No, I'm not.
Yeah.
Okay. Okay, I think it's 10 o'clock and maybe we shouldn't have any questions. There's just few things that I want to say before we close the session. I think both Abhishek and Bharati have told very clearly what should be done and how it should be done. A half an hour or 1 hour or 2 hour session of infection control is not adequate. So my suggestion, since this is an NNF activity, my suggestion, all fellows and all DM, DNB students should compulsorily undergo an infection control workshop, just like they do ventilation, KMC, breastfeeding, lactation management. So that's one suggestion. The second is your question as residents and fellows would be, what do I do in an emergency? So for that, my answer is that if you start doing these things routinely, it becomes a habit, and therefore in an emergency, and even when nobody is watching you, you're going to do it. So please, please, please practice it every time for every baby all the time. The third message I want to give is, it's not only that you should practice it, you should make sure that everybody around you are practicing, and you have every right to pull up a person who is not following the practices correctly, but do it politely. Okay? And the last comment is that I think whenever you're having your ventilation workshops and focus or whatever, every session should end with an infection control aspect of that particular workshop. And I think Abhishek mentioned that he thought of this program basically because the students didn't answer. So my request to all the examiners or the budding examiners is to make sure that you start asking questions on infection control, start preparing OSCEs on infection control, and I'm sure everybody will follow the practices. But this is not purely from an exam point of view. You should walk into the NICU telling yourself, today I'm not going to do anything wrong as far as infection control. In fact, I'm not going to do anything wrong for the baby. And particularly, I'm not going to give any infection to the baby. And if you do that every day, I'm sure our babies will be much, much safer. Thank you very much for having this session. And I think we need to do more of these sessions, both for our fellows, residents, and nurses. Thank you.
Thank you, ma'am. I think your messages are very well taken, ma'am. So with the permission of everyone, can we close the session today? Thank you all. Have a very good night.
Yes. Thank you. Thank you.
Thank you.